Good evening, everyone. It's my great pleasure to welcome you to this Jacobson Lecture. My name's David Byrne. I'm Pro-Vice-Chancellor of Newcastle University's Faculty of Medical Sciences. I'm actually a clinical neurologist by background as well. I'm also Director of our NHS England and NIHR designated Academic Health Science Centre, which is called Newcastle Health Innovation Partners. If you can bear with me for some housekeeping matters, they obviously are important. Please can we ask that you keep your phones on silent. We're not expecting a fire alarm, so if the alarm does sound, please follow the instructions of the event stewards and make your way out of the building to the car parks. And if you would like to tweet about tonight's lecture, please use #InsightsNCL. And following the lecture, there will be an opportunity to ask questions. I should say we've also had some pre-submitted questions as well, so you'll forgive me if I interdigitate the odd one of those as well. So you've heard me say this is the Jacobson Lecture, and the Jacobson Lecture is actually endowed by a generous gift from the Ruth and Lionel Jacobson Fund. The lecture is given annually on some aspect of medicine, and they've been running these lectures since 1965. They've featured some notable and renowned names. And tonight's speaker is no exception to this star-studded lineage. I'm delighted and honoured to introduce tonight's Jacobson lecturer, Amanda Pritchard. I also would like to extend a warm welcome to her parents, John and Wendy Pritchard. Amanda is Chief Executive of NHS England, which leads the NHS's work nationally to improve health and ensure high-quality care for all. To remind us all, the NHS in England currently employs around 1.3 million people on a full-time equivalent basis. That's 1.4 million people in total. And Amanda is also accountable to Parliament for a pretty small budget, NHS's £150 billion of annual funding. Her prior role was NHS England and NHS Improvement Chief Operating Officer and NHS Improvement's Chief Executive. As I think some of you are aware, Amanda's got significant first-hand experience of the NHS at the sharp end. She was previously Chief Executive of Guy's and St Thomas's NHS Foundation Trust. She joined that trust from the Chelsea and Westminster NHS Foundation Trust, where she spent 6 years as Deputy Chief Executive. She actually joined the NHS through its graduate management training scheme in 1997. I'm delighted to say that we've had a number of trainees through this scheme coming through our Academic Health Science Centre. And you never know, one of these days they could be standing here as well. Amanda's also served as Health Team Leader in the Prime Minister's Delivery Unit. Since the NHS is a part of all of our lives and is frequently in the news for a host of different reasons, I'm sure that we're all really looking forward to hearing Amanda's lecture tonight, which is entitled The NHS of the Future and How We Get There. Amanda, thank you.
Well, thank you very much indeed, David, and hello everyone. It's a real privilege to be with you today. I've always thought of the North East as home because I spent my formative years down the road. Actually, I'm probably pointing in the wrong direction, but down the road in Durham, and it's great to be back. It's actually particularly great to have my parents here who still live up in the North East. Great also to be able to support Newcastle University's public lecture series. Newcastle University is an incredibly valuable partner to the NHS. You've just heard some of the ways in which that is very clear, but there's also a hugely important role in training the workforce of the future, as vital as we know that is, but not just in training the workforce of the future, actually helping us shape that future through innovation, through research, through evaluation, much of which, like the research done here on things like type 2 diabetes, is genuinely world-leading. I also know how important an institution, the university, is to the community here in Newcastle and the wider region. We often talk in the NHS about our role not just as a provider of health services and not just as a local employer, but part of our wider responsibility and our wider role as an anchor institution, truly part of the communities we serve, and with an active interest in working with partners to support those communities to thrive. And that, I know, is a role that the university takes incredibly seriously. And this public lecture series, of course, is a great example of that. So thank you again for inviting me to be part of it. So I've been asked to give my thoughts on the future for the NHS. But to properly root that, I want to just spend a little bit of time sharing some facts on what the NHS looks like now. As David says, I'm the Chief Exec of NHS England. That means I lead the organisation which leads and oversees the NHS in England. Because, as you will all know, the NHS is not one organisation. It is thousands of organisations. And within those organisations, as we've just heard, there are an awful lot of people. So just taking hospitals and community health services, you've just heard the figures, they employ around 1.4 million people. To put that in context, there are around 56 million people in England, about 36 million of those are working age. So what that means is, this is a question for how quick your maths is, roughly one in every 24 working age adults in England work directly for an NHS trust for at least part of their time. Our people work in all kinds of places, the obvious ones, hospitals, GP surgeries, but also less obvious places like schools, colleges, universities, homeless and domestic violence shelters, prisons and immigration centres. And they do an incredibly wide range of jobs. There are around 350 different roles within the NHS, so you can theoretically get pretty close to filling this entire lecture theatre with NHS staff without duplicating job roles. And those roles are everything from doctors, nurses, engineers and scientists, analysts and therapists, cooks and cleaners, and of course, accountants and managers. So we may not be, I recognise this, the absolute most popular of the professions. I would just say try running an organisation of this size without us, though. But the reality is, the NHS is and always has been a team. And as a team, we deliver a huge amount for patients. I am going to give you some figures now, so bear with me. GPs and primary care staff now provide about 1.4 million appointments every day. So that effectively means they get through the population of Newcastle in about 2 hours. Maternity teams deliver about 1,600 babies every day. We've all heard the phrase, haven't we, one born every minute. Well, actually, if we're being precise, it's one born every 54 seconds. About 250,000 people attend a planned appointment for secondary care, so that's about the population of Gateshead plus Durham thrown in for good measure. More than 32,000 people call 999 for ambulance services. Around double, again, call NHS 111 for urgent support, and about 65,000 people attend A&E or urgent care services. All of that every day. So that means roughly in the time I've been talking so far, the number of people that have turned up in A&E would fill about half the seats in this room. About 16,000 people a day need to be admitted to hospital wards as emergency cases. So to put that into perspective, that's about the same as every single Newcastle University student who graduated last year and every single member of staff all being admitted to hospital on the same day, every single day. So if you add up all of that with all the various other ways in which people access care, it gives you a total of around 2 million people in contact with the NHS every single day. So that is about one person in every 30. What does that mean in practice? So that means more patients sleep in NHS beds each night than there are hotel rooms in London. This one I like even better. Our teams clean an area the size of Gibraltar every day. Catering services dish up around 327,000 meals a day, which is about the same as inviting everyone who lives in Washington and Sunderland for dinner. So why am I giving you all these facts and figures? I don't think there are many students in the room, but for anyone who's now beginning to feel nervous about an exam at the end, let me reassure you, I'm not expecting people to remember it. But I'm telling you because of two reasons. The first is because if you listen to some of the voices out there, I think you'd be forgiven for thinking the NHS isn't really doing anything at all, that nobody wants to work for us. And the truth is, yes, it is really difficult at the moment. We always knew that it would be difficult at this stage of a pandemic, because we're still in that sharp end recovery from the pandemic. It is difficult for a lot of patients who are waiting longer than we would want them to for tests or for treatment. And it is difficult for a lot of our staff who feel they've been sprinting to keep up for a pretty long time now. So we're honest about that truth. But at the same time, it is also true that the NHS is responding to that challenge. It is doing a huge amount, and it is adding new and innovative things all the time. It's shown it can do that over the 75-year history of the NHS, whether that is developing new procedures like cataract surgery, IVF, or combined heart and lung transplants, or delivering major public health improvements, including HPV vaccines, which now means we have a realistic chance of eliminating the threat of cervical cancer by 2040. We also saw the real strengths of the NHS very obviously during the COVID pandemic, supporting research into treatments that have saved the lives of millions of people, not just here, but around the world. Being the first health system in the world to roll out vaccines with over 150 million doses given so far, and innovating to keep other services going at the same time with things like mental health crisis lines, video appointments, virtual wards. And at the same time as doing all of that, even just in the last few years, we've continued to make amazing strides on new treatments, new tests, new ways of accessing care. We've rolled out, for example, new gene therapies to treat children born with inherited conditions. We've integrated new at-home tests into the pathway for bowel cancer, which is reducing the number of unnecessary colonoscopies and helping us find people who need care more quickly. We've massively expanded the range of services available through the NHS app. Around 34 million people now use the app, which is twice as many as use TikTok in the UK. We've also made DNA testing widely available, taking the research done here and elsewhere over decades and translating that into genuinely game-changing clinical application. So all of that sounds great, but what I'd like to do is just explain why it matters. And I'd like to tell you a story about a little boy that I met last year. His name was Reuben, and he was just over a year old when I met him. And Reuben had been really unwell right from birth. At 5 days old, he was vomiting. His mum, Eleanor, told me she was unable to feed him. So less than a week after he was born, he had to be admitted to intensive care. Initial investigations found high levels of ammonia in his blood, but they couldn't pinpoint a cause. Now, previously, the next step would have been a liver biopsy, which is something you really don't want to do if you can avoid it. But thanks to the fact that the NHS now provides rapid whole genome sequencing, his care team were able to narrow it down to a specific gene function with just a simple blood test. What that meant was that they could quickly give him the correct medication, stabilise him, and save his life. So now, thanks to that treatment, he's had a liver transplant, and all being well, he has many healthy years ahead of him. So Reuben's story is about why all of those things I've just said really matters, and why I think we can be legitimately optimistic about the future. And that's partly because it's not just that. Even over the next few years, there are many more advances that the NHS can look forward to benefiting from. Artificial intelligence, it is not just science fiction. It's already being used in the NHS to assess things like brain scans for stroke patients. But it's got far more potential. It's got the potential to do things like help us predict illnesses so you can take steps to prevent it. It's got the potential to do things like speed up administrative tasks and decision making so clinicians can spend more time with patients. And it's even got the potential to have conversations with patients to help guide them to the right services or give them the right information. And over the next few years, we can also envisage the next steps and further advances in genomics and precision medicine, allowing even faster and more accurate diagnosis, meaning more people can benefit from tailor-made drugs that reduce side effects. Wearable gadgets, mobile apps, another area we can see real potential. Already, we're using it to do things like develop the closed-loop systems for type 1 diabetes that we're rolling out now that monitors glucose levels, automatically releases insulin without the user having to do anything at all. And all of that is either happening now or it's within touching distance. And there are more on the horizon, which I'll talk a bit more about in a minute, but all really exciting stuff. But it is only part of what the future looks like. And that brings me to the second reason why I shared all those statistics a few minutes ago. It was to give you a sense of the scale of the NHS now, so that you've got the context when I tell you how it's going to have to grow. Why? Because our need for care as a population is going to carry on growing. Over the next 15 years, the population of England is projected to grow by 4.2%. But as part of that growth, the number of people aged over 85 is projected to increase by 55%. Now, that is a really good thing, but it's also a significant challenge for the NHS. It is stating the obvious, but the use of health and social care resources rises rapidly with age. In 2015, average health spending was 5 times greater for an 85-year-old than for a 30-year-old. And that's because 7 out of every 8 people aged 85 or older live with at least one long-term health condition. And in fact, at that age, you're more than twice as likely to be living with 3 or more long-term conditions than you are to have none at all. At population level, the decade before the pandemic, we saw more than 25% increase in the number of people living with major illnesses. Now, that's projected to increase by another 36% by 2040. So that's an extra 2.4 million people with ongoing health needs, not far short of the entire population of the North East. That increase in demand and need, of course, isn't just about physical conditions, and it isn't just about old age. 1 in 10 teenagers were thought to have a mental health disorder in 2017, rising to 1 in 4 in 2022. By 2040, it's expected that over 4 million more people will be living with anxiety or depression, many of them alongside other physical health conditions. So, just as it has for the last 75 years, the NHS will need to change if it's going to meet the needs of our communities over the next 75 years. What does that look like? Well, at a very basic level, more illness means we need more capacity to respond. We need more people, we need more places, we need more equipment, we need more drugs. Partly, of course, just as we always have, we will also look to what I was just talking about before, new innovations, new medicines, new technologies to cure or help us better manage some of this additional illness. But we should be clear, these things do not come for free. Experience from the last few years has taught us that ever more specialised treatments, even when they're not a cure, means even greater price tags. Since 2018, NHS spending on branded medicines has been increasing at a rate of over 5% a year, and that doesn't include COVID treatments. So while the possibilities for the future, particularly these new innovations, are a cause for real excitement, they are also likely to pose an ever greater quandary to those whose job it is to balance the books. And the drugs bill isn't going to be the only quandary. As they always have been, Governments of whatever colour will be anxious to limit the sum cost of the NHS, and that is right and it is understandable, because governments have got many other spending priorities that they are responsible for and accountable for balancing. And they also have to be mindful of what money is coming in through the door. So the state of the economy and what we can produce. In the short term, the economic outlook is under a constant spotlight. We've had it today, haven't we, and yesterday about inflation. But what we don't often talk about is what the long-term outlook is like. I realise, by the way, this is going to quite a dark place. I promise this is going to get better. But right now, for every one person at state pension age in the UK, there are roughly 4 people of working age. By 2045, it's projected that that ratio is going to be more like 1 to 3. And that ratio factors in increases in the state pension age, but that doesn't, of course, necessarily dictate when people start to become ill or when they leave the workforce. If we don't factor in those changes, the ratio becomes more like 1 to 2. Enough to send a shiver down the spine, I suspect, of leaders of public services of all kinds, and not just here in the UK. This is something that many countries are seeing and have seen over recent decades. So, yes, the NHS is going to have to grow, but we can't afford for the NHS just to grow. We will need to do things differently, as we always have. I've talked about harnessing innovation, the things I've talked about that are in the near future that we can see right ahead of us, and they do have the potential both to deliver better outcomes for patients and boost productivity. Looking even further out, 2030 and beyond, we see the potential for even more game-changing innovation, which may do the same. Things like mRNA technology, groundbreaking work that's going on right now in this country, giving us the potential to find and deploy personalised immunotherapies for some of the world's biggest killers and even some cancers. Things like regenerative medicine, now offering the potential to treat illnesses by reprogramming cells and even to grow or 3D print your own organs rather than wait for a donor transplant. And things like nanotechnology, offering the potential to target and repair individual molecules or cells to treat diseases like cancer, leaving healthy cells intact. The prospect of the NHS not just being able to use these finished products if they do come to fruition, but to help in their development and the development of others through our partnerships with industry and universities is incredibly exciting. But it's only part of what the future looks like. So we know we don't have the luxury of sort of picking a moment in time in the future and planning a service for that. The challenges we're held accountable for are the immediate ones. The financial forecasts we're given to plan with and to work with are, 5 years at best. So what have we got to do? We've got to build, we've got to rebuild the plane while we're flying it, and sometimes while we're navigating it through a storm. But we are clear that in that context, and given everything we can see on the horizon, the task we have falls into 3 main buckets: recover, strengthen, transform. So firstly, continue to recover from the effects of the pandemic. That means prioritising improvements in access to the services people need. It means continuing to improve safety in urgent and emergency care through faster treatment, increasing access to mental health support, reducing waiting times for elective care and cancer care. We have made progress on all those things. We are making progress on them. But my goodness, the job is far from done. It also means addressing some of the other challenges the pandemic brought, such as recovering productivity and how we deliver care. The NHS is already one of the most efficient health systems in the world. In the decade before the pandemic, our average annual growth in productivity was more than double that of the wider public sector, and actually 7 times that of the wider economy. But the pandemic and recovery from the pandemic has had a significant impact, seeing experienced clinicians and managers leave, taking institutional knowledge with them, as well as seeing new and different services and ways of working brought forward, which now need to be optimised to ensure we're doing things as effectively and as efficiently as possible. So recovery. Secondly, we need to strengthen. That means focusing on our workforce, delivering what we set out in the NHS long-term workforce plan last year. Another statistic for you. The NHS currently has over 110,000 vacant positions. So that is about the same number of vacancies as Sainsbury's has staff. Filling them would be like selling out 10 nights at the O2 Arena in London. Easy maybe if you're Taylor Swift, but not quite so easy when you're an employer looking to find people with the right skills and looking to find people with really, in many cases, highly specialist skills. So when we were developing the long-term workforce plan last year, we worked out that that shortfall that I've just talked about could grow to 360,000 staff by 2036-37. And that's why we need to do something about it, and we are doing something about it. The long-term workforce plan, which, by the way, the first of its kind in the NHS's 75-year history, set out how we want to massively increase the number of key clinical and supporting posts in the NHS over the next 5, 10 and 15 years. Part of that is training. So we've secured funding to create tens of thousands more clinical training places over the next 5 years. But we know we're going to need the help of the higher education sector, of Newcastle University and many others beside, to establish and recruit to those courses. Importantly, that's not just the traditional degree route and the traditional degree courses. It's a far greater number of apprenticeships. That includes medical apprenticeships for the first time, making sure we don't exclude those for whom, for whatever reason, going to university just doesn't work. The other part is keeping hold of the staff that we do have for longer. Because if we want a better staffed NHS, we need people to want and be able to stay. So we need to be a good, modern employer. Now that means lots of things. That does mean people need to be appropriately recognised and rewarded for what they do, very obviously, but it is also making sure that they have support for their own health and wellbeing needs. It's making sure people have the opportunities to develop and learn new skills. It's making sure that they can speak up and help change things that should be better. And it's making sure that we are being flexible in accommodating life outside of work. And crucially, that has to be the case for everyone who works in the NHS. The NHS benefits from an incredibly diverse workforce. But we need to continue efforts to ensure that people, particularly people from ethnic minorities, aren't held back, aren't forced out of the NHS simply because of who they are. The NHS as a service is here for all of us. As an employer, it must be open and fair to all of us too. Strengthening also means doing everything possible to ensure those staff are working in decent facilities and have access to the right technology and equipment, not just to do their jobs, but to do them well and to do them productively. So, we're working now on developing a comprehensive plan for national NHS infrastructure, which will set out how we can build a modern, productive and safe health service. We're clear that that is going to need to be underpinned by significant capital investment, and we got some in the spring budget a couple of weeks ago for technology. And we're clear, though, that we are going to need further investment in our physical estate. Lots of it predates the NHS, and some of it is Victorian. Even some of the slightly newer buildings from the 60s and 70s are now well past their safe working lives, and the backlog maintenance bill runs well over £10 billion. So we're under no illusion that delivering a modern, fit for purpose estate, while vital in supporting staff to work most productively, nonetheless presents very difficult choices for whoever is holding the nation's purse strings at the time. So anyway, that's recovering and strengthening. Thirdly, we need to transform the way we deliver care. Now, part of that I've talked about, that's continuing to embrace the opportunities that technology offers, providing more services in a way that's more convenient for patients, and continuing to integrate and harness the incredible amount of data that the NHS manages, so clinicians and leaders can benefit from the insight it provides in optimising services, whether for the patient in front of them or the entire population they serve. But the other and more fundamental part is far more dependent on humans. We can't expect people with multiple different needs to have to go to multiple different places to get them met. So we need far greater integration and partnership working that recognises the whole needs of every person who comes forward. So yes, that definitely means joining up various parts of the health system, GPs, community services, specialist care, but it is much wider than that. A couple of months ago, I went to spend time with the team at the Jean Bishop Integrated Care Centre in Hull. They bring together a range of services for older people in their area living with frailty, the NHS, but also social care, also voluntary sector, even fire and rescue services, all working together with the goal of helping local people lead happier and healthier lives into old age. But we know that model isn't just applicable for older people. Another visit, another time, I was up in the Cosy Cafe in Dudley and I saw NHS professionals working hand in glove with voluntary organisations and with patients themselves to support people with a learning disability and autistic people to live the lives they want to lead. Just like Jean Bishop Centre, it's avoiding hospital admissions, it's avoiding acute care, but more importantly, it's delivering real change for those people. A man I met there, Nathan, told me that he was moving into his own flat that day. He was hoping to learn to drive and that he had gone 9 weeks without harming himself. Now that had been unthinkable for Nathan before, but now he's doing it, and he's doing it thanks to the support he got from that joined up person-centred service. So as important as Ruben's story is, as a sign of what the NHS is doing now, can do more of in the future, thanks to innovation, Nathan's story is far more indicative of how the NHS and other services will have to work in the years to come. The other major shift that we have to make is to focus ever more on catching illnesses earlier and preventing them from developing. And with that, we must, as an NHS, but as a country too, keep up the focus on health inequalities that became so obvious over the pandemic. The health inequalities that mean, for example, if you're a baby boy born here in Newcastle, on average, you'll live 1.5 years less than another boy born in Northumbria, but you'll have almost 2 years more than a baby boy born in Middlesbrough. Now, the NHS cannot solve this alone. No one agency can. But just like the examples I've given a moment ago, this is going to take partnership across multiple public services, but also crucially with communities themselves. There are already some just brilliant examples of that kind of approach in action. Take hypertension or high blood pressure. Millions of people are walking around with it. They might not know they have it, but it means they're at greater risk of heart attacks and strokes. Now, hypertension can be really well managed with lifestyle advice and medication, but only if you know you've got it. Now, that can happen at any GP practice, the vast majority of high street pharmacies too, but that relies on people coming to where we are. And we know that a lot of people, for a lot of reasons, don't do that until it's too late. So we have to go to where they are. And that is increasingly what we are doing. So on a visit to Barnsley last year, I saw how the local council and the NHS have joined forces to take blood pressure checks around local neighbourhoods, including barbershops and markets and community centres. So they've tested about 5,000 people across the course of the year, and more than 1/3 of them had high enough blood pressure to be signposted on to get help from their local GP or pharmacy, and where they could then get the support they needed to get their blood pressure down, bring down their risk. And you can apply the same principle to other inequalities. A few weeks ago, I was talking to some GPs in Manchester, and they'd identified in the area where they worked, they had a particular inequality that for rough sleepers, and particularly women, they were facing the most serious health inequalities but they just weren't coming into the surgery. So rather than wring their hands or shrug their shoulders, they went out and they bought a van. And they kitted that van out with a consultation room in the back, and they started working with homeless charities and services to go where those communities were. They provide sexual health and contraception services as a way in, and then they use that opportunity to identify people who need further clinical help and encourage them to get it. There are countless examples of this all across the country. And while they look different in different places based on the particular needs of the people who live there, we need to ensure that across the whole country, the NHS is playing its part in a cross-society drive to support people to live happier and healthier lives and to reduce the inequalities that we know exist and we know hold us back as a country. And I think that's a good point at which to leave you with some questions to think about. I know you're going to ask me questions, so I'm just getting in early. I've set out what I think are some of the key challenges facing us now and some of those coming down the track. I've described what I hope resonates with you as some of the really, I think, very credible and very exciting opportunities that we know exist. But I've also set out what we need to do and what we are doing to bend to those challenges, to set ourselves up to take those opportunities. But if I'm being really honest, for the most part, I have only really covered how we're responding to the generation now reaching older age, the baby boomers, how we benefit from what they have brought to the world, but how we adapt to meet their needs now they're entering older age. What about the generations that have followed them? How can we keep the NHS sustainable for them? Those questions, if you truly unpack them, are far wider than those that I can answer. They speak to very deliberate choices we have to make as a country, and that other countries will also have to find their own solutions to. Because the health of an individual owes far less to the provision of clinical care, to what we mostly do in the NHS, than it does to a myriad of other forces that act on us in our lives. It's how we're parented, our education, the experiences and opportunities we're able to access, what we put in our bodies. It's where we live, our housing, the quality of our environment, access to green spaces. It's whether we have a job. It's whether that job is secure. It's whether it pays enough to live. It's whether our employer takes our needs seriously. It's about the quality of our social networks, the ability to seek comfort and assistance from friends and family. And increasingly we see it's the resilience to the content and behaviours that are a feature of social media. So the future of the NHS is actually dependent on the health of society. And the health of society must be a far wider discussion, one in which we ask ourselves some uncomfortable questions. Do we really mean it when we talk about giving every child the best possible start in life? Are we serious about delivering dignity and quality of life for all in older age? Are we fine with the fact that it's easier for kids to buy calorie and fat-laden foods on their way home from school than it is to buy healthy snacks? How do we strike the balance between protecting employees and promoting employers? Are we prepared to do what it takes to have enough good quality homes? Do we continue to accept that some households can't afford to heat their homes over winter? Just this week, the NHS opened the 15th specialist gambling clinic in Sheffield. But are we really okay to just carry on doing that as a response to the 24/7 ways of gambling and the ever more sophisticated methods employed to keep people coming back to them? Those questions speak to the kind of society we want to live in, that we want our children or our children's children to live in. And one of the questions some people are asking, you may ask me later, is whether the vision of the NHS as founded by Nye Bevan back in 1948 will survive another 75 years or even to its centenary. If you want my view, and I'm going to assume because you've stayed with me this long, you might as well have it. I agree with what Bevan said to 13-year-old Sylvia Beckenham back on the 5th of July in 1948 as she lay in her bed at Trafford General Hospital, having been presented to the world as the very first NHS patient. What he said was that the NHS was a milestone in history, the most civilised step any country had ever taken. 75 years on, the British public continues to overwhelmingly support its core principles, free at the point of delivery, available to everyone, and primarily funded through taxation. It would therefore, I think, be a very brave decision to try to sell the public on a vision of a British future without the NHS. But equally, and perhaps more so, it's going to take many brave choices in the coming years to deliver a future in which the NHS can survive and can thrive for all who need it. And if I had one piece of advice for those doing that job in the future, those Prime Ministers of the future, it would be to quote Bevan again. And it might not be the line you're thinking of, but one which I hope will resonate for many of us, whether you're involved in public service, in charities, volunteering, or just in parenting. The story goes that Nye Bevan, when addressing Barbara Castle back in 1948, told her, "Barbara, if you want to know what all this is for, look in the perambulators." So that is prams to you and me. I think he was right. Because what better reminder is there of the need to make the world a better place, even if that means difficult decisions now, than looking into the face of the generation that will, for better or worse, inherit it from us. So to any of you who find yourselves in positions of having to make those kinds of difficult decisions in the future, keep looking into the perambulators. You will find all the courage you need there. And to that end, I just want to leave you, as I look around this audience, I think there may not be very many students in here tonight. But if there are, I want to speak directly to them, if I may. And it's just giving you one last thought to mull. So if you're a student, you probably know what I'm going to say, but I'm going to say it anyway, because it would be remiss of me to come to a university and not give a recruitment pitch. So here it is. If you weren't already thinking of a career in the NHS when you finished your studies, or if you're mid-career and you're thinking about what else to do, what next to do, and you haven't been put off by my describing the challenges ahead, then please do think about a career in the NHS. So I've worked, as David said, I've worked in the NHS for over 25 years now, and it has not always been perfect. Some days you do need to look in a lot of perambulators, but I have always considered myself to be lucky to be a part of the NHS, because there aren't many careers where you get a chance to make a huge positive difference to people's lives every single day and work with people who are enthusiastic and inspiring. For the educators in the room, you might feel that you count in that group, but wherever I go, I meet people for whom a career in the NHS hasn't just been about transforming other people's lives, it has transformed theirs too, whether that's ongoing training and development, whether it's the relationships and the friendships that they formed, or just the satisfaction of having done a good job for patients. So whatever you're thinking your next step might be, now or in the future, there will be routes open to a career in the NHS. So please, if that resonates with any of you, please do think about joining us and help create that future, which is exciting, which is within our grasp, but which is going to take some serious hard work in the years to come. Thank you.